Great. Welcome everybody in person again and for everyone online. So my name is Aviva Ariel and I am the health psychology intern at Jesse Brown, also the student chair for Division 38. So on behalf of Northwestern and the Jesse Brown VA, I'd like to welcome you all today. Again, for those of you streaming online, if you will type into the chat box where you're calling in from, so your program or organization, just so we get a sense of how far and wide we're reaching. I'm honored today to introduce Dr. Nancy Beckman, who is an assistant professor of clinical psychology in the Department of Psychiatry and Behavioral Neurosciences at the University of Chicago. Dr. Beckman received her PhD from Rosalind Franklin University. She completed her internship at the University of Chicago Medical Center and her postdoc fellowship at the University of Illinois at Chicago. Dr. Beckman's clinical and research work has focused on coping with and adjusting to chronic medical illnesses, health behavior change, anxiety disorders, and behavioral medicine integration. And today we're thrilled to have Dr. Beckman present on health psychology within primary care. Thank you.
Thank you. Okay. Okay. Thank you. Right. So I'm very happy to be here and to present to all of you. I'm going to be talking about integrated primary care. When I trained in various health psychology settings and am a health psychologist, but I never had a formal training in primary care. I think that reflects how far that's come along in the more recently. And so, when I started at University of Chicago back in 2014, there's such a huge demand for increased mental health services in a lot of the different clinics, but especially in primary care. And so that was sort of part of my job, was to sort of help get that going. And so we've done a lot of work to integrate it. And so it's been sort of a work in progress, and I've been learning a lot too. Much of the material that I'm covering today kind of comes from some of the things that I've learned. I took Alexander Blount's course from the University of Massachusetts. So some of that was from him. And then also the Division 38 has a really great, adapted from the Division of 38 Society for Health Psychology. They have the integrated primary care course. And so a lot of the slides that I've taken are from that. So it's a really great 4-part series that I encourage you all to check out. Okay, so just a little outline of what we're going to talk about today. So first I'm going to review just the rationale for integrated primary care, prevalence, the need, the goal, all of that. I know that I might be preaching to the choir about the importance of behavioral health services, but I also think that just reviewing that information is important, in part because, I think there's a lot of ways that health psychologists or that people, when they're involved in academic medical centers, can sort of start some of this work or really advocate for it. And I think that to be able to speak the language and to give some of the facts about why it's so important, quickly and easily, can help with buy-in from administrators and other people. We're going to just discuss some of the features of integrated primary care, and then a lot more about just the psychologist's role. So screening, assessment, intervention. So hopefully this will be a little bit more heavily on clinical work. So what would you actually do if you were in this place? Then touch on some of the unique diversity and ethical issues, and hopefully we have time for a few case examples, and then questions at the end. Okay. So to begin, we know that mental health problems are really prevalent within primary care. Kessler and Stafford in 2005 point out that, of the patients who have mental health problems, 70% of those are usually treated in primary care versus 30% in specialty mental health settings. The first time I saw that, I think I was surprised that was such a large discrepancy. But many of the patients with mental health problems, go undiagnosed, especially if routine screening is not in place. And providers aren't necessarily trained on how to look for it and assess it. If you put in routine screening or give them some training, the rates can increase, but that's not the case everywhere. And then there's also big concern that many of these patients are inadequately treated. So for example, they may have been started on a dose of an SSRI, and that same dose has never been titrated, it's never been adjusted, nobody's really following up to see if the patient's actually taking it. And so without sort of behavioral health providers to check in on that, the estimate is that less than 33% of those patients are getting minimally adequate care. So those are sort of staggering numbers. And so then if a mental health problem is recognized, right, if we can overcome some of those barriers and a referral ends up being made, then there's really a lack of access to outpatient mental health services. So 66% of PCPs say they can't access outpatient mental health. And then when a referral is made, up to 90%, so like about 10% might actually end up an appointment being made, which is so low if you consider how that has just funneled down to being so few patients. And that's particularly true. The Office of the Surgeon General reports that racial and ethnic minorities are particularly less inclined to seek specialty mental health services. They're more comfortable going to primary care. And so these are some of the reasons why this is really important. And so we also know that many medical presentations have psychological comorbidity, right? So like rates of depression and anxiety are much higher in different medical conditions among the medically ill. And then like conditions such as diabetes, heart disease, pain, asthma, when they're comorbid with an untreated mental health condition, they're also associated with poorer outcomes, poor compliance, something that happens a lot when we also have comorbid mental health issues. And then untreated mental health problems are often the source of a lot of medically unexplained symptoms, which can be sort of really taxing on providers and the system, and also a source of sort of unnecessary treatment for patients as well. So we also know that the high utilizers, the people who use the majority of the services, so 10% of patients use 70% of resources, and those 10% of patients tend to have that comorbid mental health medical illness. So in general, untreated mental health tends to lead to double the cost. It's sort of a rule of thumb. There, in one study controlling for comorbid medical problems, patients with depression were found to utilize 3 times more healthcare services, have 2 times the medical costs, and make 7 times the emergency room visits. So, and they're associated with poor outcomes and higher mortality. That's especially true, for example, people with severe mental illness. I don't know if you've heard that. They die on average 13 to 30 years earlier than their age cohorts in the general population, largely due to preventable illnesses and diseases. And so it's a really prevalent issue, right? We've got a lot of untreated mental health within primary care setting. We know that it leads to higher morbidity and mortality, insufficient care, higher cost. So because of this, this is sort of the rationale behind why integrated care was seen as important, sort of to address some of these issues with access to improve our mental health, so our healthcare system, not our mental health care system. So like a general sort of there's different models that have been developed, but a sort of a model neutral definition of integrated primary care is just care from a team of both primary care and behavioral health clinicians working together with patients and their families. So on any of the many different problems that patients can bring to primary care. And it can address stress and physical symptoms, life stressors, crises, maladaptive health behaviors, acute chronic medical disorders, substance misuse. So one of the things that Alexander Blount would say in his course that, one of the goals is that for any problem that a patient might have, they come to the right place. There is no wrong door, that we can see everybody and kind of triage as we needed. The other thing that he said, so one of the marks of like truly integrated primary care would be when behavioral health care is an integral part of the medical treatment and the medical care site. So that providers are all operating from a single treatment plan with both behavioral and medical elements. So we'll talk about how there's different stages of where someone might be in the process to integration, and how that sort of full level of integration is something that I know at University of Chicago we're still striving for as well. So sometimes we kind of fall a little bit short of that. And there's so there's also sort of goals of doing this in a systematic, a cost-effective way, with goals of providing sort of better service, really monitoring the population health, right? So we're making small changes in a large number of people rather than making a lot of change in a small number of people. There's administrative and financial barriers to doing this, to getting this going, and I know that's sort of particular to different places. one of the challenges we have, even though it's like clear there's a need, I think just the way it operates where I am, that you kind of have to demonstrate that first. So you kind of have to throw yourself in there and show that you're failing, not failing, but that, that you can't keep up with the demand in order for them to say, hey, maybe you need something more, versus kind of showing those numbers beforehand. I think that's probably the case in a lot of places. So that's useful to know. There's some other models. So I'm talking about integrated primary care where the behavioral health and primary care are working together. Some of the other models are collaborative care, so with the same concept. The collaborative care model came from sort of the landmark studies. Are you guys familiar with the impact studies? Some of you are nodding. The impact study from the Ames Center, they did a huge study with like about 1,800 people, depressed older adults. And they randomized half of them to treatment as usual. So that would be the treatment as usual that a person would get within primary care, which is being started on medication or being offered a referral, or to the collaborative care model. And the collaborative care model, the way that's a little bit different than primary care usually involves the primary care, the patient, the primary care physician, usually a case manager of some sort, who's managing a registry and keeping track of where the patient is on different sort of benchmarks, and consultation with a psychiatrist. And so the patients who are in the half of the patients who are in the impact part, they were assessed, they were offered medication, or they were offered treatment, like sort of behavioral treatment with the case manager. It usually sort of problem-solving therapy, kind of with a motivational interviewing and behavioral activation. It's kind of to be like integrated within the problem-solving therapy. And so they would be, if they chose that, they get calls either in person or by the phone once every week or every 2 weeks. And so there were different, like the first 12 weeks they had that, or medication with the consultation with the psychiatrist. If they weren't getting better, then they could, at the end of that 12 weeks, they would switch. But of course, they're monitoring and checking in. So the behavioral plans might be changing, the medication might be being adjusted. And so that went through sort of 3 phases. By the end of 12 months, half of the patients receiving the collaborative care had a 50% reduction, at least in depressive symptoms, compared with only 19% of those in the usual care. So it was quite remarkable. And then even after the trial ended, when they looked later at more longitudinal data, that the patients in the impact arm had 100 more depression-free days over the next 2 years. And so this sort of focused care, integrating it, seemed to have this long-term benefit as well. So there's some other places. Cherokee Health Systems, the VAs, are very well known for their collaborative models. There's also patient-centered medical homes. Have any of you worked with different types? What are you familiar with? Patient-centered medical home. And so that's really supposed to help coordinate like all the elements of the care, because that can be really overwhelming especially when you start to see patients who have high medical needs and mental health needs, that they have all of these appointments and all of these things, but to have a place where all of that's coordinated, that's very helpful. Anybody else?
And it was like our office as a therapist was right next to the primary care doctors. So if something came up in the appointment, they literally walked them over and we could see them same day.
So you weren't in the same place, but you were so close, and there was like this fluidity of same day services. That's really great. Okay. So you get to see sort of it's done in sort of a lot of different ways in different places. So the goal of integrated primary care is often referred to as the triple aim, and this has actually been upgraded, and I think that recently when we talk about to the quadruple aim, the fourth part that isn't listed here, is paying attention to the provider experience, reducing burnout, making sure that providers aren't overworked and overstressed, making sure that they're getting adequate training and support and improved processes. So that's important. I like the quadruple aim more than the triple aim. And so, but the goals there in terms of patient-centered care is to provide the best care, So you're improving the patient experience for the whole population, right? So we're trying to avoid these disparities at the lowest possible cost, and the goals there can be interconnected. So it's so it's not just because we're trying to do this at a cost savings, right? If a patient is going for less diagnostic procedures, yes, that's going to cost less money, but also we might save the patient a lot of unnecessary treatment and other things. So it can lead to both reduced costs and improved outcomes. And so, some of the results in practicing in this integrated way or with the collaborative models sort of are consistent with the triple aim. So we're seeing positive results that in general, patients are using sort of less of the high cost, high intensity services like emergency room visits, hospitalizations, and that things like adherence, screening, patient visits to primary care, so just the routine medical treatment that a person should be using, are increasing. And this reflects this idea that a lot of these models are sort of helping to improve patient health understanding, patient access, and sort of self-management of their condition. So rather than sort of neglecting to the place of then we need to do an emergency service, we're able to sort of take care of it as the problems are developing. And this is what I referred to before, that there's differences in levels of integration depending on where you were. So right when I started, we were siloed. So we had the Department of Psychiatry and we have the internal medicine. And patients get referred, some of them make it through. Occasionally there's communication, right? Like if there happens to be a very difficult case or something like that. So it's very siloed. And then the next step is co-location, when you're sort of at least in the same place. And that's why I say that when I sort of look at where we are in our levels of integration, where we're sort of somewhere between co-located and integrated, and sometimes we're 3, sometimes we're 5 to 6. And I think we're moving forward, and so it's nice to be able to see that. So being in the same location, obviously that's important, right? So to reduce lots of those barriers like transportation, cost, all of those kinds of things. The communication, so also having integrated medical records in the system. So that was one of the hurdles that we had, because psychiatry tends to write in a separate, it's protected in different ways. And so finding ways to make sure that we could chart in the same place as the medical providers and that they could see our notes, that those were sort of shifts that had to happen system-wide within the hospital in order for us to practice in that way. But then when we think of being fully integrated, so we're there, we're in the same site, we have shared systems. We send all our notes back to the referring provider. Sometimes we have warm handoffs or the same day consultations. We'll talk to them, before and after, but we don't do that routinely for every patient. And there are lots of providers who probably don't think of behavioral health with every single patient in the same way. So we still have some room to grow for full practice integration. And part of, I think, what holds us back is that we're not there full time yet. So we will be hiring we have a full-time psychologist who'll be starting in the new year. And so then we'll be on site all the time versus now we're there half the time. We have clinics every five half-day clinics, but there's periods when we're not there. And so they have to still practice in their old way and refer to us. But it's improving in lots of different ways. So they usually say that the highest degrees of integration occur most frequently in community mental health centers, the federally qualified health centers, or large organizations. Often Kaiser Permanente in California is something that's cited. That's sort of a place where both the insurance company and the provider are one and the same. And so there's cost benefit and incentive to providing behavioral health services, as we just discussed. And then the VAs and the other military organizations are very large based hospitals. Those are probably places where the greatest strides have been made. And so there's suggestions on how to grow a practice, right, from one level to the next, depending on where you are. One of the things that we've done at U of C is so we have a behavioral health integration program, and so we periodically do the level of integration survey, and we give it to all the providers within primary care to talk about, where do you think we are on these different places, and then pick one of the places that are low and do a lot of interventions just to target that specific area to see if the next 6 months whether we can have improved that. But some of the strategies are, developing skills to conduct brief consultations. So when I say that, for example, I wasn't trained in primary care, I was trained, I had consultation skills from, other sort of integrated, behavioral medicine settings, but to really be within the primary care setting, to learn how to be quick, how to be to the point, how to speak their language and really adapt to the culture, I think in a little bit more of a way. Even when I come as a psychologist to the pain clinic, or I come as a psychologist to oncology, I still feel, I feel separate, I think in some ways more than when I'm within that clinic. And I think these are really important, becoming really part of the formal and informal primary care culture. So like attending the staff meetings, getting to know everybody, the billing, the front desk, the nurses, all of those things. One of the more experienced nurses who'd been there for a long time had said, we really need somebody on Monday mornings and Friday afternoons. That's when patients are in crisis. That's when we need somebody. And luckily, one of our students was able to do the Fridays, and it is tough. But I think that sort of the people on the ground often have this perspective for what's really needed. So kind of when I say that, going about improving it in a way that sort of is step by step. So kind of getting that needs assessment. Those are the people who really know where the needs are. And then encouraging warm handoffs. So that does like a huge service towards, so do you guys know what warm handoffs are? I keep using that phrase, right? So that's the same day service. And that really builds on the relationship between the provider. So, some people are new to their primary care physicians, but a lot of people have been with their primary care physicians for a long time and they consider them a friend and they really trust them. And so if that person says, I really think that would be useful for you to see my colleague who's an expert in helping people deal with diabetes, or my colleague who's an expert in helping people deal with stress. I think this is going to be helpful for you right now. That really does a lot for buy-in. So some of the differences between specialty mental health and integrated primary care, I think of sort of, again, the goal is sort of more of a generalist setting. And so kind of like the difference between a primary care doctor and an endocrinologist. And I think I often thought of generalist versus specialist even just as a health psychologist, but I think that it's less special. Health psychology tends to be specialized to a specific like GI or trauma or something like that. And so you kind of have to, be a jack of all trades in some ways. So services are typically provided on site in real time. The real time makes such a difference because we know that motivation can, wax and wane. And so if in the moment that patient's crying and saying like, I just can't stand this anymore, that might be a good opportunity for someone to come in and do something. And then also it relieves a lot of the physician burden as well for them to know that they feel supported when they're having a more difficult patient experience. So we're trying to work together as an integrated team with a single treatment plan. And one of the reasons that's, I think, very useful, and I can see that in our work sometimes, is because you're getting sort of reinforcement for that plan from every single angle, right? So if everybody is saying, how is it going with your medication, right? What's happening, right? Versus, we start to get like a better sense of like this patient's actual adherence, and we're all working together, we're all talking, we're all reinforcing it. There's really, in order to work in this way, there's the focus on brief interventions rather than longer treatment than you might see. And brief interventions are possible because we're really focusing on early intervention, right, before problems become the full-blown disorders. So smaller, interventions, really encouraging people toward more self-management can help sort of ward these things off before they become problematic. And there's sort of brief interventions that are thought to occur over time. So with this idea, this is a long-term relationship. So every time we see this patient, we do this brief intervention. You actually might sort of move somebody further along on a stage of change or in their behavioral, any sort of behavioral change. So again, the focus is not just mental health. It's also on health behaviors, substance misuse. So you kind of need to be familiar with all of those things. Dr. Blount talks about sort of, usually within primary care, there's a little bit less, patients might be less disturbed. That's not necessarily the case. I think depends where if we were fully integrated all the time and triaging the patients who had high mental health needs, that might be the case. But I think since we're sort of there now, we kind of, the first people that get referred are usually the people who it's like very obvious need help. So, but they might be less diagnostically clear. We're doing much briefer assessments. And that sometimes is hard for me as a person who was trained in the specialty mental health to do this super comprehensive evaluation to let go of some of that and to not ask every single question that I know would give me like a completely I'd completely have ruled out every single thing that might be wrong with this person, but to instead focus on what do they need right now with keeping in mind, some important, risk assessment and general rule outs to kind of keep that focused, even though I might not really know, if this person has like an OCD, I notice that their hands are dry, but right now they're talking about this particular issue, and so we're going to focus on that. That sometimes is, I can feel like a tension for my training to the new place, but it's possible. So you have to develop a little bit of a tolerance for some ambiguity, some uncertainty with those things, and develop more of a problem-oriented approach. So I think lots of different activities, right? It's one of the things that I love about being a health psychologist. You're involved in working in an academic medical center, involved in a lot of, your hands in lots of different pots. So this slide provides just a broad overview of all the range, the different clinical activities that a psychologist might perform. So like health behavior interventions, so smoking cessation, alcohol reduction strategies, sleep improvement, exercise plans, so kind of being familiar with mental health and behavioral health. Care coordination is really important, being able to refer to the right person. So that's a skill that I feel like I'm developing since I've been in primary care. When you're operating more in a siloed place, you kind of sort of take care as much as you can, and you just don't refer as often. But especially given the demand, right? If we can refer, oh, this sounds like something the social worker can help you with. This sounds like something that this person can help you with. We're sort of trying to work with all of the resources we have. We have the smoking cessation group. So rather than me doing the smoking cessation, we're going to try to give you all the things that you can use. And then chronic disease management there at the bottom. That's one of these big bucket items that includes adherence, group medical appointments. Sometimes we don't do those as often. Some places do. Managing the emotional impact of an illness on the patient and the family. So other roles and skills, and these I've sort of learned that sort of coaching, you're doing a lot of behavioral medicine coaching, right? So if the idea is that the reality is that primary care providers are like the mental health providers, right, for 70% of these patients, and even being integrated in the way that we are, we cannot possibly see every single patient. So the more we can sort of raise the skills of every single person, the better off the care will be for all the patients. And so we do a lot of coaching. So, so I'm sorry, I can't see that patient, but, maybe something that you can try is X, Y, or Z. We're also really heavily involved in behavioral medicine teaching for the medical residents. Which I really like. So residents are there for 4 years, and so we are part of the behavioral medicine curriculum for the PGY1s, and we precept with them. We go in and talk about ways that they could, make it more patient-centered. They could talk about mental illness in a non-stigmatizing way, those kinds of things, and little brief behavioral interventions that they might use in a smart way with their patients. And because they're there, we get them year one, then they get a little bit more comfortable in actually referring to us. And so then over time, our residents develop sort of relationships with us. And so we're still also working toward staff. We're doing more MI. I'm currently doing a series of MI trainings for the staff, how to deal with difficult patients, those kinds of things, ways to talk to patients, and attending lectures and those kinds of things so that everybody can increase what they're doing. So we're really working for that system transformation. One of the things that's useful it's like learning how to document, that becomes important as well. So, in specialty mental health, it's all private, right? We're keeping everything secure. But here I usually talk with patients about the fact that, what I'm writing is going to be in their general medical record. And if they have any issues with that, we try really hard to keep the notes as bland as possible. So, and I tell them if there's anything that you're going to talk with me about today that you don't want in your record, to let me know. If it's not, if it's really important that your doctor knows, I will share it with your doctor privately. There might be some caveats of certain things we might need to put in the medical record, but so I kind of give them the choice of whether they want me to sensitize their note and send a private message, or whether they want it to be there. But then even when I keep it, I try to keep it as bland as possible. Stress at home. Stress versus the dirty details of what just happened. So it's important to be flexible, and it's also important to sort of kind of blend a bit in with the medical culture, right? So medical culture, some of the differences that I know, that I've seen is that there's more of a focus on hierarchy. You have to be professional. I wear my lab coat whenever I'm there. I don't necessarily do that when I'm in, but lab coats are sort of common within the hospital. I don't necessarily do that when I'm just sort of seeing outpatients in my own clinic. I refer to myself as doctor. Those kinds of things are not things I necessarily do, but if you want to be respected equivalently there and seen as a professional, then I think that it's important to sort of follow that culture rather than being an outsider in that way. The medical culture is really fast-paced, focused on the bottom line. I think sometimes I like to theorize and talk about, like, isn't that interesting? Like, whoa, what, and so really trying to be focused and saying, like, okay, this is what they said, this is what's going to happen, this is what I think you need to do, right? Kind of trying to keep it to that quick pace. But I think at the same time, I think when I first went over there, I was trying so hard to adapt to the medical culture. I think in some ways, sometimes I forget that at the same time, I think that your psychology training, the whole reason why we're trying to integrate behavioral health is because we offer something too. And I think that idea that, you have sort of a unique insights and appreciation to the psychosocial aspects of a person's health, trained in more of these sort of patient-centered ways of really listening to a patient, those kinds of things. And so sometimes if you're trying, we can still take that. We can still, even though the time might be shorter, we can still practice those same basic skills and listen to a person and validate them and try to use our communication skills as best we can within that setting, like especially the motivational, active listening, reflection, so that people still leave that appointment not feeling rushed and like unheard, but they feel like they were heard and listened to and understood. So that's what psychology can bring. Okay, so we know that there's the supply-demand imbalance, as I mentioned. So one of the things that we're very involved in, excuse me. So we're trying to raise the behavioral health competence of all the providers. And so I'm part of the primary care behavioral health integration program. And we have a physician champion, Dr. Latirapong. She's wonderful. She's a real go-getter and is able to put so much of this stuff together. But we meet as a team with with psychiatrists, with other people from primary care. I'm there, so we sort of develop a lot of tools so that the primary care physicians and other people can use them. So there was I think Medicare last year said that within 2 years, everybody needs to screen for depression. And so the MAs, the medical assistants now, are delivering the PHQ-2 when they room patients. And then if the patient scores above 3, they give them the PHQ-9, and then the PCP comes in the room and has to deal with that. But then what does the PCP do, right? So we've developed a lot of these tools where, so it kind of takes them through step by step. If it's high, then ask them if they're suicidal. We have a suicidal algorithm for them as well. And then what to do. Start the antidepressant. On the bottom of this page is this. This was developed with our psychiatrist, Dr. Hannah. Of where do you start? What might be a good idea for something to start, depending on the patient's issues. And then you can see here at the bottom, measure the PHQ-9 every 4 weeks. So that sort of kind of address some of those issues when patients are started on a medication, but it's never appropriately titrated. When do you up the dose? When do you switch? So we've produced a lot of these kinds of tools on panic disorder, I said suicide. We're developing one on interpersonal violence. There's one we're developing more and more, so that it's really sort of putting all of our behavioral health and medical expertise together to kind of create quick algorithms for the providers to use. I'm really proud of those. I like those, and I see them when I'm in the workroom. I see people like referring to them, and it makes me happy. And sometimes I do too, when they ask me a specific question about a medication or something that I'm not as familiar with, that that becomes a quick reference for me too. So one of the ways that psychologists can improve the identification of issues is to implement broad-based screening. So behavioral health screening can assist primary care providers with like identifying those things that are less obvious. And so these are some of the most common things that are used. The PTSD is a post-traumatic, it's a 3-question primary care post-traumatic stress disorders, asking about like hypervigilance, numbness, those kinds of things. And then substance use, alcohol and drugs. So screening and then assessment, right? And so this is what I'm thinking more of like what we do when I come into the room with the patient, what kinds of things I might add. So I'm just gonna skip here. So this is sort of what Division 38 has put out is sort of how would you structure that 30-minute appointment? It's quick. So that was really probably like one of the biggest shifts for me, right? Moving from a place where I was always somebody who kind of edged on that 60 minutes, right? So I was somebody who really used the full hour all the time. So this was tough for me. But so to spend that first time giving an introduction to who you are, what your role is, the whole point of primary care and why we're here. So really trying to do that in a non-stigmatizing way, trying to get an understanding of the problem and then doing the intervention, but really in a shared way, one that's empowering to the patient where they're figuring out what's possible, like utilizing their own resources, those kinds of things, but sort of with some of your guidance. Wrap up the post-consult feedback, all administrative tasks in the last 5 minutes. I'm not there yet, but I'm sure some people have gotten there. Okay, so Eric, will you help me? I'm gonna do the, where were we? Just down here? Okay, so this is an example of Kirk Stroessel. Are you familiar with him from acceptance and commitment therapy? He's great. He does focused acceptance and commitment therapy, which is a shorter version that can be used within the primary care setting. But this is just an example of his intro. Sorry, guys. Sorry about that. Trying to get down for the first one. Yes, are you done with her, or do you? Sorry, I'm going to rewind that.
What we're trying to do is address all aspects of your health and well-being so that it includes your physical health also. Emotional health, how you're adapting to life challenges, stresses, transitions, that type of stuff. And so if any of those things come up during a visit, which they do very often, the doctor can text me and pick up one today. This chapter 15 or 20 minutes, we're trying to get a clear picture of what's going on in your situation right now. And together with you try to come up with a plan. So sometimes that means people want to come back because they think they might be able to build some positive momentum and money a few times. Sometimes people kind of get what they came for, they know what they need to do in their life, and they're done. And they also do not do it. We'll kind of figure that out at the end when I'm done talking to you. I'll leave the doctor with that as your kind of bring further over. If you're talking a couple of things, you're having trouble with anxiety, you're spending a lot of time and by yourself, and problems with anxiety you start.
I'd say it's been a while, but it's been.
So I'm just going to stop that. So really that was to show you the basics of the introduction, right? So you heard, you didn't really hear because of the volume issues, but the PCP gave a warm handoff, right? So it was saying, this is David, he's been dealing with anxiety. Dr. Stroessel asked a couple questions, are you finished with him? Okay, and then sat down, he introduced himself, he introduced what the service is, talked about the reason for referral. Is that what brings you in today, or is it something else? That's really the basis, I think, of how we started as well. So then it's going to ask him a bunch of questions to figure out where exactly he is with that. Oops. Okay, sorry, just wanted to. So one of the things you can do was, so we're trying really hard to focus on the present when we're talking to the patient. So she's presenting this specific issue, at least with that patient. We're trying to pursue the questions that really impact intervention, right? So we're not just asking questions just to kind of get this detailed history of the person. We want to know, like, is this going to matter or not for what we're going to do at the end here? So selectively using open-ended questions and reflections. I think that this is where motivational interviewing skills come in because of the short time frame, that using like the agenda setting. So he kind of set the pace that, we're going to spend 15 to 20 minutes. At the end, we're going to do this. It kind of helps. At least I know for me, it gives me permission to then interrupt somebody and say, okay, so now we're going to move on to this part. Summaries are the other thing that I think from motivational interviewing that's really helpful for me in this setting to say, okay, let me stop you there. This is what you've been talking about. And then I do a summary and a question to keep moving it forward. Dr. Stroessel talks about, and this is a useful way to think about that, the 3 T's, the times, the triggers, the trajectory of what's been going on, so like, when did this start? How often does it happen? What happens before? What happens after? Why do you think it's a problem now? The triggers, is there anything, situation, a person that seems to set this off? What has this been like over time? Does it wax and wane? Time when it's less of a concern, more of a concern? And I added workability, right? Because sometimes people talk about solutions that might not be workable. So from ACT, where, is this a solution that's really going to help you create a more meaningful, richer, better life that's sort of pushing you towards the life you want to live, or is this a solution that's going to drive you crazy? Sort of asking how has this worked in the short run? How has this worked in the long run over time? The other things that I usually do try to do time. I think of the 3 T's, and love, work, play, health is probably the other thing that I ask a lot, and that I find that really helps kind of get actually a social history, right? If you ask who's important, who's in your life, what kind of supports do you have, what do you what do you do, what do you enjoy doing, what's a typical day look like for you, what kinds of things do you like doing, and how's your health, right? So even for the patients who might have been referred for anxiety or stress or something like that, asking about their health, really, that's one of the ways that I find that I'm practicing integrated care, right? Because then they might say, oh, well, I do, even though this was totally a patient for stress management or something completely unrelated, they might say, I had to start taking a cholesterol medicine. I'm really upset about that. And so we can actually work that into the treatment plan. And the other thing that I often do is also ask about just their resources. So what are their current coping strategies? What are their sources of support, right? So if we're trying to build a self-management plan, it's useful to know what are their resources. So this is one of the ways that they often sort of divide patients, sort of thinking about the care needs that you might have within any sort of given clinic, with one being the patients with the lower behavioral health needs, lower physical health needs. So those might be patients that even the primary care physician can manage, right, with just a little bit of consultation or something like that, or with some of our behavioral strategies, versus to the quadrant 4 with the patients with the high behavioral health and the high physical health needs, who, I think it's especially with those patients that you see you really benefit from the team approach, where, sometimes I see these patients who are so sick that before they leave, I would really like to ask the doctor if this first patient is medically safe enough to leave. They're not taking any of the medications. They all seem really important. Is this okay? So kind of talking to them and letting them know those kinds of things. And then being able to access more case management and that kind of stuff can be helpful for those patients. Some of the cases that we have at the end, I tried to find patients that might sort of fit into these different categories. And so different integrated models sort of might focus on one or more of them. So for, you might be more likely to refer out a patient with really high mental health needs. Some places might operate in that way to find the specialty services that best fit that person, not sort of, so. It's helpful to have a primary care toolbox, right? That's sort of what I think about. I wear my lab coat, so I have space in my pockets. I also have a thumb drive that I can use for a lot of these resources and things, so that I can pull them up quickly while I'm there. Just because of the way psychiatry is sort of housed, I can't access some of my drives when I'm over in the other places of the hospital, and so I carry everything in my thumb drive. But so this is great. So if we're trying, these kinds of things help enable this visit, because I'm feeling pressed for time in a lot of ways, right? And I want it to go smoothly, efficiently. I want to sort of keep myself focused as well, with the goal of, so having handouts for common conditions, like what is depression? What is treatment for depression? That can kind of help guide the discussion too, right? And keep people focused. There's a panic disorder one that I really like. These are common symptoms of panic disorder. These are sort of thoughts that might increase panic. What are some thoughts that decrease panic? These are, some strategies that you can use in the moment. I think we try to do grounding strategies, and avoid avoidance. So it's sort of like a 4-part little handout, and we might just focus on one. We might just do the psychoeducation component and a little bit of the cognitive, and send them home with that as something to keep practicing. And then if they never come back, they have that handout, so they know what the next few steps would be. So those can really be helpful to keep things focused. And then obviously if we're trying to get them, like the goal is to empower them to be active, to self-manage, themselves, you have to really think about using alternate resources, because they're not just coming to see you, right? So if I'm not going to see this person again for 3 months until they come back for their next visit with their PCP, what can they do at home? So so we've developed a little bit of I know I have my favorite apps that I tend to refer people to. And what about you guys? Do you have any of those that you're using in any that I haven't listed here that are relevant?
Breathe to relax. The two.
Breathe to relax.
Yes.
What is that? Breathe.
It's like it helps with like diaphragmatic. Like I think there's also like imagery that recommended that a lot on CL.
Okay.
Patients.
Calm.
It's a really great app, but in order to unlock there's but it's like a great thanks. Meditation studio has a lot of free meditation.
Okay. I was using Stop, Breathe, Think for the longest time, and part of the reason was just because they had a couple guides. They had a mindfulness of breathing, which I thought was good. So if I taught somebody diaphragmatic breathing, there was like a 3, 5, and 10-minute free version of just breathe in, breathe out. So I was sort of trying to supplement that together, and it was simple. So just go here, press mindfulness of breathing, and do that. Lately, and then if somebody gets bored with those, then I'd switch them to something like Insight Timer, where there's this whole slew of things. I've been using Insight Timer more often because if I'm suggesting progressive muscle relaxation, they have some scripts there. Virtual Hope Box is something that was developed in the VA. That's really great that it has space to develop coping cards for, especially I think it has it has a relaxation. It has like a distract me, relax me, empower me. It has 4 different sections where you can put good happy pictures, right? So sometimes when patients are really sort of distressed, if in the moment, what are you going to do? A lot of times patients will say, I look at a picture of my grandson, and that's what kind of helps me get through that moment if I'm feeling suicidal or something like that. And so there's a place to do that as well. MediSafe I've been using as a pill reminder for patients. I use it, and so now I'm familiar with the ins and outs. So when patients come back and they say, I didn't know, she's like, it was really annoying. It was going off when I was out of home. I was like, oh, well, there's a GPS feature that you can say snooze until home, and it uses your GPS and then reshakes once you get home. So that being able to be a little bit familiar with it has been helpful. It doesn't. No, it's free, and it shakes, and so it shakes or you can set whatever you want it to. And I always say that we like to pair it with a commitment. So that's what I did, a commitment that I'm not going to turn off this alarm until I take my pill. And so it annoys my husband. It annoys everyone around me when they hear because I'm watching a movie and I don't want to get up to do it. And so I'll just let that, it'll shake on its own every 10 minutes until I do it. So I'll snooze it sometimes, but I won't turn it off until I've taken my pills. And so that was my commitment to myself, and so I often talk to that with patients about that as well, so that they can, you kind of have to use them together. Otherwise, you're completely annoyed by it after one day, and then you're going to throw it away. But it's sort of the negative reinforcement, right? So we're taking it, that shaking it sound away. Okay. Copies of screening measures, as I said, so when you're doing the assessment, sometimes you'll have patients come in, you might wonder, like, I think I need to do a MOCA on this person. I don't know if, I get a lot of older adults. Or ADHD kind of recommendations, evaluations where somebody's like, should I refer this person to neuropsych testing? So kind of using us as a first line screen to see whether or not this is warranted. So we have lots of screening measures that are available that we can do kind of quickly within that setting. Our business cards, how to access, right? And so we do encourage people to contact their primary care physicians as much as possible, with knowing that the primary care physician is our, we're working with them, but we let them know how to contact us in between. And then a lot of information about community resources. So, how can you get patients be involved in their own community? And this is one of the things that we're working a lot on at University of Chicago, that for patients with certain insurances in certain locations, it's really hard to refer them to specialty mental health, because I do get a lot of patients with high mental health needs. And so we're trying to find more partnerships with people so that we can have more easy access of referrals for all of our patients. So McDaniel has put out, and other people have put out, what are some of the competencies for psychologists who practice in this way. So some of the basic ones that I think is effectively using current evidence-based interventions appropriately for primary care to treat both health conditions and mental health issues. So cognitive behavioral therapy, motivational interviewing, psychoeducation becomes really important, problem-solving therapy. And so I think sometimes I see that it's not considered, light, CBT light. I actually think in a lot of ways it has sort of focused me to have to be able to really distill the absolute most important elements within a short period of time. And then, so in some ways I feel like I've become a better cognitive behavioral therapist because of this. Can you also focus on self-care, functional improvement, symptom reduction? So having sort of that toolbox of health psychology tools. I put sleep hygiene, a lot of places do, because the CBTI protocols fit nicely within this setting as well. And can you bridge the continuum between, primary care, are you communicating well, and specialty mental health resources? So some of the common goals, I often say that I think that if the patient never comes back, and you always will assume, right, that this patient might never ever come back, so this was your only shot with them, that if you clarified a diagnosis, you educated them about what it is and what you thought a treatment plan would be, that at least they have that information that they can take to their next provider. They kind of know what to do down the road. And then sort of that's why I really try to find interventions or things that they can take from their own resources. A lot of times we're trying to, find ways to improve their overall health, encourage more activation. So we do a lot of behavioral activation as a first-line treatment for depression, other things. Foster self-advocacy, helping them with communication issues when it comes to operating within the medical system with their other doctors. Using things like mindfulness skills, distraction, relaxation, breathing, anything to help reduce anxiety or improve distress tolerance in the moment, cognitive restructuring, and then that care coordination. So those are some of the common clinical interventions. Is anybody familiar with the 5 A's? Right, so I think this fits nicely with, and this is something that it fits nicely within primary care, within a medical model, and it's something that you can, I think I learned it through smoking cessation, but it really fits nicely with any medical issues, right? So if you're assessing, asking them about the problem, advising, I think that there are ways to do this in a little bit more of a motivationally consistent way, motivational interviewing kind of consistent way, trying to agree on an action plan and help them arrange that. What I've been using is brief action planning. I've included a link here. Is anybody familiar with brief action planning? It's really structured approach based on motivational interviewing and the 5 A's and some of this action planning literature. Basically, you ask, what is one change you'd like to make for your health in the next week or two? And I've done this in other specialty clinics, right? If I'm talking to endocrinologists, what's one change you'd like to make for your diabetes in the next week or two, right? So people might shift it a little bit based on that. Some patients will say, I'm going to do this. And then we can help them kind of make that smart. Some patients will say, nah, I'm not interested, right? Like, is it okay if I ask you again at the next visit, right? So that's kind of helping sort of bridge that long-term relationship with the brief intervention. So we say that the commitment to asking just that first question, we tell the PCPs and the residents that we teach that asking that question at every visit is actually a behavioral intervention, especially if we're focusing on something, because we're planting the seeds for self-management with the patient. Some patients will say, I don't know, do you have any ideas? And that's where you might offer a behavioral menu. Well, other patients have tried, trying to exercise more. Some patients have tried to make diet changes. Some patients have tried to do more adherence. Do any of those sound like something you'd want to do, or is there something else you can think of? That's kind of a behavioral menu. So you're constantly getting the patient's feedback. Well, they might come up with something, and of course your goal is to make it more specific, measurable, achievable, relevant, right? Time-based, so that they have a better chance for success. A lot of times we'll hear, the patient's going to lose weight, right? So they can't just lose weight. You have, or you can't cut out all pop. Or if the patient's drinking, the only thing they drink is pop, that's not a realistic plan to say, I'm never going to drink pop again. So, how can we get them to make that more specific so that they might actually have more luck with it? How confident? That's the next question you ask. How confident are you? So let me summarize this plan. You write all the details out. How confident are you that you can do this? If they're right, so this is a motivation, using confidence rulers as a motivational interviewing technique. If their confidence is less than 7, we might ask those questions. What makes it a 7 and not a 2? What makes it a 1 and not a 0? Right? If somebody's down there, so we're trying to get at some of the reasons why they want to do this. Why is it a 6 and not an 8? And they'll say that helps you elicit some of the barriers. So then the job is to problem solve around some of those barriers. Well, I don't think I'm going to remember. Well, so we might do the same thing. Use anything that you can think of that might help kind of overcome that barrier. You can use a behavioral menu. Other patients have set an alarm. Some people write Post-it notes. Some people ask a family member or somebody to remind you. Do any of those sound like they work for you, or is there something you can think of? Some people will say, well, I just don't think I can do this 5 days a week. That's where you might modify the plan to a place where it becomes a little bit more possible for them. And then, would you like to set up a time to follow up on this plan? Is ideally how it works within brief action planning. Sometimes you have to shift that based on like the clinic schedule. What would you like to do? Sometimes when I really think that somebody needs sort of assistance with that, if they say, can you email me in 2 weeks? Yes, I can email you in 2 weeks and check in to see how that's going. And then you kind of do the same thing. How did it go with your plan? And you encourage any change, small change, big change, 100% change. That's great. Have you thought about what you'd like to do for your health for the next week or two? And then you keep revising the plan. So doing this every time, that's sort of one of the ways that I sort of try to make the action plan that we're doing at the end of a session a little bit more behavioral. So these last few slides, are we out of time? Oh, okay. So the last few slides were just so the common things that I might do for some things like depression. They all are involving basic psychoeducation and then some behavioral interventions, right? And a lot of those are things that you're familiar with. I did this for anxiety. We do a lot of worry time. One of the things that we do in primary care, a lot of times we see patients who are their PCPs are trying to get them off their benzodiazepines or maybe onto an SSRI. And so we sort of work with them on boosting their behavioral skills to help them throughout that process. Chronic pain is more of a medical condition that we see a lot of, where we do a lot of psychoeducation on the gate control theory, sort of things that they might do to be able to use their brain to help manage their pain. Cardiovascular disease, where we might provide education about the different risk factors, and then there's like a whole host of things that you might do to kind of help start to target that. And we really think one change over time, even if it's a small change, might increase your confidence, your motivation to do the second change, and so that change begets change. There are some unique diversity and ethical issues that arise in practicing in this setting. So really being like aware of sort of my health beliefs might be different than my patient's health beliefs. The role in the family might be different. The presentations of somatic symptoms might be different. Wanting to provide culturally competent, linguistically appropriate care for people. So you might have to use interpreters, those kinds of things. But there's a lot of boundary conflicts and other things that come to play in primary care. So And part of that is because APA ethics and AMA ethics are a little bit different, right? So I think one of the real common things are, I think AMA gives them medical doctors a lot of autonomy to choose their patients, or we have like roles of trying not to have dual relationships with patients. And so, what do I do when one of the staff who is treated in that primary care, who I'm working with, comes for therapy, or when it's the husband and the wife coming to therapy for me, or when it's a family presenting. So it presents lots of issues that as a specialty mental health professional sort of makes me, gives me pause to think. And that's really what we encourage, right? So you're trying to find what's the common ground there. We don't want to do any harm. We might have to explain this and talk to the patient or to the provider who might be making a referral that you feel uncomfortable with, about like how we're putting patient stuff first, patient safety first. A lot of consultation. I think in a lot of ways this is new, a lot of new areas that you're breaking ground with. So I will stop there. Thank you for your attention. I'm sorry for not leaving enough time. Does anybody have any questions?
What's the average number of sessions? So
we see patients for up to 5. That's what we say. And that's because we're not there full time yet. And so, so I think we are kind of sort of this bridge between specialty mental health and nothing. And so that's what we're doing as a way to keep it managed. And so we sometimes say that, and if you're going to need more than that, then we can talk about how we're going to refer you. So it's sort of using us as a bridge to longer term treatment.
And is it 5 sessions over 30 minutes, or is it like?
Yeah, so 30 is what we try to do for all of our sessions, but sometimes they're a little bit quicker when people come back. Sometimes it's 20. That always feels great when it's 20. Okay, occasionally, I think, and as I say that sometimes in our setting we're a bridge to nothing, to especially mental health. Sometimes we do have really serious patients, and if I don't have anything scheduled, it might take longer. But there's a lot of case management and other things happening.
Well, what's your
So I do half scheduled. So if I'm there for 4 hours, I'll schedule somebody for like the first hour, the first half hour, and then leave the second half hour open for consultation, those kinds of things. And I usually try to do a mix of new patients and return slots so that I can see both. As we're sort of sometimes, as we've had shifts, I mentioned that the nurse said that people have meltdowns on Fridays. And so our student who's there on Friday, she's been regularly getting 3 like warm handoffs every clinic, at least 3 every clinic. And so, she was kind of booked. She was often booking like 5 or 6 patients in her 4-hour clinic. And so, because it's hard because we have such few services that sometimes when you see a patient, you're like, okay, fine, I'll schedule you. So that's a boundary issue. But so we're really trying to keep her at 4 because I'm like, you are always, or even 3 because you're always getting 3, and probably when I'm on maternity leave, you're going to get more. And so let's keep you where you are. So it's a balance, and I think it changes depending on like what you recognize. Like I've had some clinics where you don't get any warm handoffs, and so that might be where I would, overbook or something.
Outpatients tend to be more receptive, or
Like since we've been there and we're integrated, so that's something that we were looking at to see if a warm handoff increased attendance at the next appointment versus a cold referral. At the time when we were first looking at it, we didn't have enough. We didn't have a high enough N for our warm handoff data to be able to compare it. But it seems to me that it's true, right? So that a lot of times people will, or sometimes they will help clarify. Sometimes they'll say, I really think I'm fine. Like I don't think that this is an issue. And so this isn't somebody who needs an appointment with me. If they have no interest whatsoever in behavioral health, and they feel like they're doing okay, okay, is it okay if we come back to say hi to you the next time you're here seeing the doctor? This might not be somebody who needed to fill up one of our slots. We can just kind of do this warm handoff thing for a little while till they warm up to us. But then there are some patients who are like, this is the first time I've ever talked to a mental health professional. It's not as scary as I thought it was going to be, and so then they are more like, they might have gotten something out of it, and they might be more likely. That's the goal. Thanks. Any other questions? Were there any online?
There were not any online today.
Okay, thank you so much. Happy Halloween, everybody.
Thank